For my practice specifically, I do a lot of electrodiagnostic medicine and testing, and then also treat spasticity, which as a med student, I don't even think I learned that at all. So I'm just going to give you an introduction on that. And then also just kind of more hands-on applicable stuff for like the PM&R application process, residency, and career options. And I think we can just leave we could leave the questions to the end. That's probably the easiest. So I still answer this question. People ask, what is physiatry? What is it, they don't even really know what it stands for. So hopefully we can answer a lot of those questions. Here we go. Even like looking for any comics related to a physiatrist, you have your stereotypes in different specialties. They don't even have one for PM&R. So I thought I would come up with one myself. So, you have your orthopedists or meatheads, you have in neurology, which is an armchair intellectual. For physiatry, I thought maybe the relaxed and misunderstood. That might be appropriate. So physical medicine and rehab, also known as physiatry, it's a branch of medicine really that focuses on the prevention, diagnosis, treatment, and rehabilitation of disorders that provide temporary or permanent functional impairment. So whereas for cardiology, you're treating the heart, really anyone that's lost any form of function, they will fit under our specialty. So you'll see that creates a very breadth of different pathologies that we can treat. So really our goal is to maximize independence and mobility. We tend to have kind of similar overlaps, say with orthopedists in terms of this mentality of how can we improve function, improving quality of life. We do have very goal-oriented, patient-centered care, and I'd say multidisciplinary care, as you'll see shortly. And with a multidisciplinary team. So what exactly do we do? So I guess the easiest way I can explain it is we maximize function by using non-surgical techniques. And this can be with medications, say to treat pain, if someone's having pain. Maybe they have spasticity, which we'll go over, and we have medications for that. We do a lot of procedures like injections that can help treat pain. And then I think we're also pretty well versed in, actually diagnosing and giving appropriate rehabilitation recommendations and exercise for certain musculoskeletal conditions. We tend to have a breadth of knowledge in prosthetics and orthotics that most specialties don't, and then also adaptive equipment. So one thing that I like about this specialty is we can kind of provide longitudinal but specialized care for a variety of patients that I've mentioned. And also you can work in sort of a variety of settings, including inpatient, outpatient, and consulting roles. Say for me, I do mainly outpatient, but also do some consulting services in the inpatient hospital. And then also we tend to help lead a multidisciplinary team. So a common question that I get asked a lot is, okay, so are you guys physical therapists? What exactly is the difference? So obviously there tends to be a lot of overlap in the type of conditions and patients that we see. Physiatrists, however, obviously went to medical school, did a residency and everything, and we tend to make and manage the medical diagnoses and then refer people to physical therapies for them to perform. And sometimes I'd say we're a lot more specific about the diagnosis and what exact exercises they should be doing, maybe compared to like a primary care physician. And then you'll see in terms of the rehabilitation setting, we tend to be the medical leaders of the rehab team, which usually involve physical, speech, occupational therapists, along with social workers. So just a brief overview of the specialty. So it sort of began around the late 1920s and 1930s to address sort of musculoskeletal and neurological conditions. This is Dr. Frank Krusen. He was considered one of the founders of the specialty. He actually was training to become a surgeon, and he ended up contracting tuberculosis. And I guess in his rehabilitation and treatment with a lot of physical medicine modalities, he became very much interested in physical medicine and rehabilitation. And he actually founded the first department in 1928 at Temple University in Philadelphia. So after World War II, the specialty definitely broadened its scope, mostly to help address and treat a lot of the returning veterans from the war. So this included a lot of patients with amputation, spinal cord injury, traumatic brain injury, and basically try to help them restore their physical function to the best of their capabilities. In 1947 was when we actually were granted approval as a specialty of medicine. Around that time, like in the 1950s, also a lot of the physiatrists became big proponents in treating patients in the polio pandemic. So even now, we still see some patients that have had history of polio to try and improve their function, say with bracing and things like that. And then in 1972, Medicare sort of expanded the coverage of the specialty to include disabled patients and inpatient rehab. So I think one nice thing about physiatry is that we tend to treat a lot of patients that I think can be underserved or maybe underrepresented in medicine. Say, for instance, like a spinal cord injury patient or a young kid that has spina bifida or cerebral palsy. And basically the unifying theme is that a lot of them have lost some sort of function. Also, they're pictured, as your sort of, like your sports athlete or your adult who has pain from arthritis. So this is a good overview of sort of how we kind of divide up the different conditions that we can treat. And as you can see, there's a really, broad depth and variety of pathologies. So neurorehabilitation, as we mentioned, spinal cord injury, stroke, MS, oftentimes these patients are seeing, say, their neurologist to help treat their MS, and then they might see a physiatrist where we're trying to help treat their spasticity or find a good brace, maybe for their foot drop, just as an example. Obviously, pain medicine, some of my colleagues maybe do an extra year fellowship in this where they're doing a lot of interventional spine injections or procedures. Musculoskeletal and sports medicine, a lot of people do go into sports medicine from our specialty, and I do think the way that physiatrists kind of think about and evaluate a patient are, make them pretty well equipped to become, to get a field in sports medicine. We also see a lot of amputation patients, limb deficiencies, and then, as I mentioned, sort of pediatric functional and developmental disorders like cerebral palsy, muscular dystrophy. And then in the inpatient setting, you can see anyone that might need additional inpatient rehabilitation, such as someone who's had a joint replacement or an LVAD. There's a whole new field of cardiac rehab that's coming into the forefront. So, we are considered specialists. So I'd say these are the most common referrals that we get in kind of descending order. I would say primary care is probably the most common referring provider, where they might see a patient that has back pain or shoulder pain and they've tried physical therapy and that hasn't worked, and they might need like a musculoskeletal specialist to try and help really diagnose and treat the problem. And then also just our colleagues in orthopedic surgery. We are in the orthopedic surgery department, so we have a pretty close relationship with them. So really, this could be somebody that is not a candidate for surgery, say for knee pain, and they really want to maximize conservative care. So that's sort of where physical medicine and rehab can come into play. So just as a brief overview, I think it's important to know different rehabilitation settings. I'm guessing most people haven't really heard about like what acute inpatient rehab is, mainly because we don't have a unit at UCSF. CPMC has one, and really the closest academic center I'd say is Santa Clara Valley with Stanford. Laguna Honda is obviously a huge skilled nursing facility, and they do have about 5 beds that are considered acute inpatient rehab beds. But this is a place where a physiatrist often serves as the medical director of this unit. It could be a unit of 10 beds, or it could be a whole freestanding rehab hospital, which they end up having, say, like on the East Coast in New York. They have whole rehab hospitals dedicated to acute inpatient rehab. But really, it's a place where you get the most, that most technology and like intensive rehab that you or I would probably want. So say this gentleman here, maybe he's just undergone a stroke or a traumatic brain injury, and he qualifies for acute inpatient rehab mainly because he has a lot of goals that he needs to achieve to get back to his baseline. So it's somewhere where he can get therapy 3 hours a day, at least 5 days a week. And he kind of has this whole multidisciplinary team trying to help him get home and increase his function. This is different from other types of rehabilitation settings that are listed here. Long-term acute care, usually those are for higher level patients that no longer need to be in an acute hospital setting, but maybe they still are on the vent or they still have needs with nursing, like with a G-tube, but they're not doing that intensive therapy with the goal of getting home within weeks. And then we've also heard of probably skilled nursing facilities where sometimes people are not even, cannot even tolerate any therapies, and they're there for a long time. The other thing with acute inpatient rehab is currently, I'd say the average stay is probably 2 to 3 weeks. Whereas years ago, maybe in the 1980s, 90s, people were staying for months. Maybe a new spinal cord injury patient was there for several months. So those are sort of things have changed along with insurance coverage of that. So, people mainly think we just refer to physical therapy and do injections, which isn't totally inaccurate, but just to give you a better sense of what we do, I can kind of let you know like what a typical week is like for me. So I kind of practice a mix of musculoskeletal medicine. I perform EMGs and then some neuro rehab. I did not do a fellowship, but I did take an extra board exam for Electrodiagnostic medicine, which is the EMG. So this is sort of what a week is like for me. On Monday, I'm mainly in clinic. I see a lot of musculoskeletal, say, patients on Mondays where somebody's come in with shoulder pain that's been bothering them for like over a year, and their primary care tried an injection, it didn't really help. So they're seeing me to try and diagnose, is it like their rotator cuff? Is it more of, maybe it's glenohumeral arthritis, things like that. So we might do diagnostic injections to help figure that out. And then I perform EMGs in the afternoon, which I'll go over shortly what that is. I also see inpatient consults. This is mainly here at San Francisco General, and that's with patients who have recently been admitted into the hospital because of a traumatic injury. The most common is usually like a spinal cord injury patient. So sometimes these are really young patients that have just been in a car accident. So me and my colleague will evaluate them, trying to give recommendations to the team how to treat like their pain, their bowel, their bladder, and also perform a neurological exam to kind of determine the prognosis of their injury. And then I also perform several image-guided injections, which are pictured there, and including, also there's a picture there of Botox, which we'll go over, which we use to treat spasticity for a lot of patients who have had, say, stroke or spinal cord injuries to help kind of treat pain and improve their function. That I had recently, just to give you a better sense clinically of what we see. So she had a right-sided stroke, probably like 5 years ago, and it caused sort of this left-sided, what we call spastic hemiparesis, which is another way of saying that she has weakness, but still has some preserved strength, and then also spasticity, which kind of relates to increased tone in that arm. And her chief complaint was right hip pain and then stiffness in the left arm. So her hip pain was sort of on the outside of her hip with like where that arrow is. It wasn't really in the groin or in the front. And it was really hard for her to walk, even though she was doing that kind of at her baseline. It was keeping her from walking distance as she usually was and from sleeping on that side. So it was like affecting her sleep as well. In terms of the arm, you can kind of see how she's carrying her arm there. This has been going on for years since her stroke. And she really can't really lift or extend that arm, but interestingly, she still has some strength in her hand. So it's kind of frustrating to her, and she really wishes her arm was, loose so that she could actually use that arm more, because she probably would actually use it if she could do that. Also, just on review assistance, she was reporting numbness in her right hand, which is her dominant hand, that is worse at night, and it affected just her first 3 digits. So on exam, she was tender to palpation kind of over that lateral hip, kind of really localized to the greater trochanter, but kind of in ranging her hip, she didn't really have much pain anywhere else. And even just having her walk down the hall, that caused her pain on the outside of that hip. And then in terms of her exam, in the left arm, she did show spasticity, which I'll go over in a little bit. And MAS stands for Modified Ashworth Scale. So she had basically had increased tone of a 2 to 3 in that in her elbow flexion, in her pronator muscles, and wrist flexors. So she really kind of, you can see how she's holding her arm in there. So basically, as I tried to range her arm, it was very resistant to motion, and that was affecting her function a lot. So basically for this patient, we kind of came up with several diagnoses. The first one was sort of what we would call right greater trochanter pain syndrome, kind of previously known as like a greater trochanter bursitis. It's kind of taken on this new title just because there's a lot more research out that it's not really a true inflammatory process, where it's actually there's an underlying issue with the tendons. And so our gluteus medius and minimus muscles attach right at that bursa. So really it's considered kind of more of a weakening rather than just a pure inflammatory process. So most of these things are treated conservatively without needing surgery or anything like that. So usually the first line treatment can be a steroid injection plus really focused physical therapy. We diagnosed her with left arm spasticity. And the plan, given it's a really localized area of spasticity, was to do a Botox injection for her to several muscles that will hopefully help her increase the range of her arm and use her hand. And that's something that I'll go over in a little bit. And then for her right hand numbness, I ordered like an EMG nerve conduction study to evaluate for really common things that can present with hand numbness, such as carpal tunnel syndrome. So all of these things come up in my practice regularly. And it can be very rewarding because these patients, these are things that they really care about and it affects their function. So kind of leading into that, I thought I'd just go over some of the common procedures that we do as physiatrists. They're all sort of listed there. So you'll see a lot of joint injections. Musculoskeletal ultrasound is definitely like kind of the new hot technology, and that's something that our specialty is becoming very well versed in, both for diagnostic purposes and then also to guide interventional injections. There's fluoroscopy guided spine injections and like nerve ablations that maybe people have heard about. People do fellowships for that. And then also some spasticity management, like with Botox injections. Some of my colleagues do acupuncture. You can actually do like an extra certification after you get your MD to do acupuncture. And then there's sort of the more experimental injections, prolotherapy, platelet-rich plasma that maybe you've heard that like some athletes are doing, or and there's also a lot of research out there for those. So I'll just go over briefly EMG and nerve conduction study, because this is something that anyone that goes into PM&R will be doing in their residency. So electrodiagnostic testing. So really, these are the two components. There's an EMG and nerve conduction study. And basically what it does is it's sort of like an extension of the physical exam, and it can be helpful to diagnose disorders of the peripheral nervous system. So this is basically everything kind of distal to the spinal cord, but within the spinal cord, it would still include like the motor neuron, which we'll go over in a little bit. And in any PM&R residency, it's actually a requirement to do this, to do 200 studies during your residency. So really anyone will be proficient coming out of a PM&R residency. The only other specialty that does this is neurology, but they have to do a fellowship to become proficient in doing electrodiagnostics. I still do these procedures all the time. Some of my colleagues don't do these anymore, but that is an option. So when would somebody even order one of these tests? So really it's anytime a patient would show signs of a muscle or nerve disorder. So usually the common symptoms are numbness, tingling, or burning pain in a limb, or weakness. So this is sort of what the machine looks like. I usually have an hour to do the study with a patient, which can be nice because you kind of spend an hour talking to them, getting to know them while you're basically testing their nerves and their muscles and trying to figure out maybe what's causing, say, their hand numbness. And really, this is a brief overview of what this entails, but just to give you a sense. So really, every nerve is electrically active. So if you were to inject an electrical current in there, you would get depolarization of the nerve and at their muscle fibers at the neuromuscular junction, you would get all these multiple action potentials, which are sort of listed there. And basically, we use this ability to do this with nerves to find out if something is normal or abnormal. So this is sort of, what our screen looks like after we inject, a little bit of current. So we're actually injecting we're stimulating electricity down the nerve, and it's getting picked up maybe at a muscle in their hand. And basically, depending on how fast and how tall those amplitudes are, that we can get a sense of if things have been damaged or not. As you can imagine, if somebody has injured a nerve and they've lost the myelin there around their nerve, things will conduct slower. So that's sort of like the first part of the electrodiagnostic testing. The second part is the EMG, which you can see in that picture. It's like a really tiny needle. It's about the size of like an acupuncture needle. And it's basically like, it's an electrode. So it's like a microphone. And we actually stick it into patients' muscles. And basically what we're kind of listening and looking for if there's been any signs of damage to the motor unit. The motor unit, which is pictured there, is just sort of all the different muscle fibers that are innervated by like one axon. So this kind of gives us more of a granular look at different muscles to give us a sense if the nerve that innervates them have been damaged or not. So this is sort of what, well, that went by fast. That's sort of what we look for when we're doing the EMG. We're actually seeing how well the sort of the size of these units, and and we use both sight and sound to determine if things are normal or abnormal. This is a good picture of kind of the different pathologies that electrodiagnostic testing can help diagnose. So there, on the far left, there's your spinal cord, and you have your sort of anterior horn cells, which are the cell bodies of our motor units. So there's, as you might know, there's several different pathologies that affect the anterior horn cell. The most probably well known is ALS, which is a motor neuron disease, which causes degeneration of those motor neurons. Another one is polio. So these things actually we could help diagnose using electrodiagnostic testing because they are affecting the anterior horn cell. As we go distally, you can see we have the roots, which I'd say the most common cause of pathology there is, say, like a disc herniation in the low back causing a pinched nerve out of the back, or radiculopathy, or some people call sciatica. And basically, as we go farther down the peripheral nervous system, all of these things we can help localize and diagnose using electrodiagnostic testing. So even at the level of the muscle and the neuromuscular junction, if someone had a myasthenia gravis, we could help test that and diagnose it using this test. So if we go back to Our Lady, so she was reporting sort of numbness in that right hand that is worse at night, and it affected only those first 3 digits. And as if we remember back to anatomy, you might remember that the median nerve can affect usually your first 3 digits along with part of digit 4. We did a nerve conduction study on her, and it did show basically abnormalities in her median nerve, and her test was consistent with a right carpal tunnel syndrome. So we helped rule out other causes and helped diagnose what that cause of her hand numbness was. So staying with the case, we were mentioning how she had something called left spastic hemiparesis, and how this was really affecting her function because she wanted to be able to use her hand like for carrying things and helping hold objects, and she really just needed that arm to be more loose. And on her exam, we noticed that she did have something called a modified Asperger's scale of 2 to 3 of several of those muscles in the arm. So spasticity. I did not hear about this at all in medical school. And so I think it's a good thing to know about. So it comes from the Greek word spasmos, means drawing or pulling. It's a component of the upper motor neuron syndrome. So really anyone that has injury to part of the central nervous system, the brain or the spinal cord, they could develop spasticity along with, say, weakness and increase in their reflexes. You might have heard of tone, which is resistance of muscle to passive stretch. So spasticity is similar, but basically the more that you increase how fast you are moving their arm, the more tone you're going to feel. So we call it a velocity dependent increase in muscle tone. And then you also have a hyperexcitable stretch reflex. So the picture there, this could have been somebody, say, with like a traumatic brain injury, or maybe somebody who has cerebral palsy, so any sort of injury to their central nervous system. And they tend to have kind of different patterns of spasticity and posturing. So we tend to have sort of like a flexion posturing up in the upper extremities, and then a more of extensor tone in the legs. And you can imagine that this can be, can cause pain, it could cause skin breakdown, and it could really affect somebody's function. So why does this occur? So really, anytime that there is a central nervous system injury, you basically start to lose descending inhibition, and you can get degeneration of these descending fibers. And then these fibers kind of react by forming new connections with new neurons at the spinal level. And when that happens, you basically can get these really exaggerated reflex responses and basically unsustained or sustained unwanted muscle contraction. And you basically just get muscle overactivity. The modified Ashworth scale is listed here. So this is something we use clinically to try to measure basically how much spasticity somebody has. So you can see there, 0, there's no increase in muscle tone. And a 4 is, maybe you try to move somebody's arm and it feels like it's just stuck. It's like a contracture. And then there's sort of a range in between in the other gradings there. So we use this clinically to really see how much spasticity there is, and then kind of determine treatment plans from that. So there are many reasons why we might treat spasticity. As we've mentioned, maybe it could improve somebody's ability to grasp something. Maybe it makes it easier for them to walk. Another one is hygiene and pain. And then sometimes for these patients where maybe they are, maybe at the wheelchair level and they're not walking, it can provide a lot more ease for the caregiver, say for transfers or like hygiene care. And then also just to prevent contractures. As you know, contractures is sort of when you get fixed, like at a joint, you can't move it anymore and it's stuck. And one of the reasons this could happen is from spasticity. So preventing that can really go a long way. So these are multiple ways that we could treat it. Really, I'd say the most common ways are the pharmacological treatment, really like casting, I would say, is not used very much anymore. Definitely doing a combination of splinting along with some sort of medication is really sort of the mainstay. So these are some medications that we use, and then also injections. Mainly the positive of injections is that there's not any really sedating side effects that can happen, say, with some of the oral medications. So baclofen, tizanidine, a lot of those can be centrally sedating. So if you want to avoid that, say, in somebody who's had a brain injury already, then an injection can be your first line, and they can last for up to like 4 months, the Botox injections. So briefly, just like for our case with our patient, the botulinum toxin injections, this comes from the bacteria Clostridium botulinum. Maybe you learned this, you've probably been learning this in medical school, but it's a family of neurotoxins. And then they actually block the release of acetylcholine at your neuromuscular junction. So this basically paralyzes a muscle for like up to 3 to 4 months. And so this can be a really good thing to use, say, for these patients with a lot of spasticity, because we can avoid those sedating side effects. And it is reversible. So that was a nice kind of whirlwind that we did about sort of examples of my practice and sort of things maybe you haven't heard about yet in physical medicine and rehab. I wanted to take the last part of this lecture to just go over like career information, especially for medical students that are maybe interested in applying for PM&R. So for medical training, so It is a PM&R or physiatry. It's a 3-year residency, and you usually come in as a PGY2. So similar to some of the more specialized programs, say like dermatology, radiology, you have to do a transitional or prelim year. There are some programs where there are 4-year programs where the first year is kind of built in. We call that like a categorical year. That's what I had at UC Davis. And it can be really helpful because you build connections and learn kind of the ropes of the hospital without having to move from different settings. In residency, it's 3 years. So usually there's a year of inpatient, a year of outpatient, and then the second is some mix of the two. And then there are fellowships, and really they're anywhere from 1 to 2 years. Most of them are 1 year. I'll go over which ones there are for physiatry. And then we do have a written and oral board examination to become board certified in PM&R. So this is data from a couple years ago. So there are 91 residency programs. I think there's 80 within the country. Those are ACGME spots. In 2017, 2018, there were about 1,000 applicants, and there are sort of your stats for unmatched spots. It is becoming more and more competitive, and you can see kind of the distribution of the residency programs. Like there's only 5 programs in California, and here in the Bay Area, or here in Northern California, there's 2. There's Stanford and UC Davis. Southern California, there's 3. So yeah, there tends to be more programs over on the East Coast, and I think that just might be because the specialty started over there. So in terms of board scores, I know, this is important for, med students to want to know. This was data from 2018. That was sort of the mean step 1 and step 2 score. In terms of research, they did cite that on average, students had about 3 research experiences. I'd say it's helpful, but not essential compared to maybe other specialties. And the research doesn't necessarily need to be in PM&R. Programs definitely look for well-rounded, students. So I'd say it's something that isn't maybe as imperative as other specialties, but it can be very helpful. In terms of fellowships, these are sort of all the different types of fellowships that people can go into. I mean, the one thing I like about PM&R is that you can kind of create a niche and have maybe a varied practice that might be harder to do than other specialties. They cited, back in 2017, they said about 43% of people completed fellowships, and those were the most common. So usually interventional spine, pain, or sports medicine. But you can do, fellowships in, say, stroke, traumatic brain injury, things like that. It's listed there. And then obviously there's a lot of different practice settings. I'd say, in terms of, group practice or multi-specialty groups are probably more common now. And usually multi-specialty groups, it can be maybe a group of neurosurgeons, orthopedists, and a physiatrist. And so I'd say that might be a common, especially in the private practice setting. And then in terms of outpatient, some people have purely inpatient practices where they're only seeing somebody in acute inpatient rehab settings. I mainly do outpatient, but with a little bit of inpatient consulting role. So there is a lot of variability there. This was just from Medscape physician compensation data that you can, look up in Google. This was from 2020. So that was sort of like mean average or mean earning that was cited. I've also seen numbers from like 200 to 280. This is just other data that we listed that might be of interest to know, sort of how much time we spend on paperwork and administration. This was sort of what is the most rewarding part of your job. I think the patient care, it can be very rewarding, at least from my perspective. This was, how many physiatrists felt fairly compensated. So I chose physiatry just because I really liked the perspective that physiatrists come at a problem, and I liked that it was sort of focused and specialized, but I still had a lot of longitudinal care with my patients. It's really hands-on, like I'm doing a physical exam like every day I see a patient, which I think can get lost in some some specialties in medicine. So we're really big on physical exam, anatomy. I like doing some procedures, but the procedures aren't, there's not really, they're not like high pressure. They can be clinic procedures. I think the patient care can be really rewarding because you're trying to improve their quality of life. And as you'll see, that's kind of what patients care about. Like for a primary care physician, they might have all these medical comorbidities, but like it's their back pain that they really want fixed. Another thing that I like is that there's the opportunity to make diagnoses. So say with like the electrodiagnostics, or say with even just an exam, you're trying to figure out what's causing their pain or what caused their weakness. So that can be satisfying. And then there's obviously a really big breadth of pathologies that we can see. And then lastly, there's not a ton of emergencies. I mean, my schedule, I don't work weekends. I don't have call, so that's nice. But I think in other institutions, if you're doing more inpatient rehab, you might be on call. But that was on the end of my list. That was it's a plus, but I would say that's not a reason to go into the specialty. And I guess just the future of physiatry. I don't know if anyone's heard this term. It's the silver tsunami, which is basically what they're calling kind of like the whole baby boomer population and all of them aging. So we're seeing a lot more people that are having sort of, musculoskeletal complaints from arthritis, back pain, things like that. So there's just an increasing demand of people to help treat musculoskeletal conditions and injuries. I think physiatrists are really probably best suited to be at the front lines of this, better than like say primary care or like surgeons, so we really kind of help fill that gap in treating these types of patients. And then also I think, we're really good at value-based healthcare and also multidisciplinary care. I think that's becoming much more appreciated in medicine. And then also exercise is medicine. A lot of these things really, exercise goes a long way, and most of these conditions get better with physical therapy and exercise. So that's the end of my talk. These are some resources that are definitely useful kind of at the med student level. Really, if there was one thing that I found helpful as a med student, it's probably the second guidebook, the Pockepedia. That's something that fits in your white coat, and it kind of goes over like everything you need to know from a med student level of PM&R. The Academy's website has a whole page dedicated to medical students. That's aapmnr.org. And then this is like an application guide that gives really specific questions about the application process for residency. So I guess I'll open it up to questions. If people just want to, you can unmute yourself. That's probably the easiest, or if you want to type it into chat.
Thanks so much, Dr. Del Rosario. Can you hear me?
Yes.
Okay, great. I was curious about the difference in number of PM&R programs on the West Coast versus the East Coast, and then also the difference in number of like freestanding inpatient rehab units. Mm-hmm. And I'm wondering if you have a sense of, is that going to change, or is that changing, or is that just kind of the setup? And then my second question is like, does that mean patients on the West Coast just don't get inpatient rehab? Yeah. I'm just kind of confused about then what happens if there aren't these freestanding facilities?
I mean, it's a really good question. And I mean, people are definitely still getting rehab here, but as you can see, maybe even within our own institution, it's not as streamlined, and it's not people don't even really know like where to send somebody to acute rehab. I think the settings just look different. Like there is acute rehab, but it's attached to the hospital rather than like this big, dedicated rehab hospital. I'd say I don't know if it's I don't know if it's really changing. I think it's just it looks different, but people are still getting acute rehab. Sorry, what was your second question?
No, I think those were the two, sort of like, is it changing, or is it just that the West Coast has a different model and that will kind of stay? And
Yeah.
then like just wondering, well, so where do all the patients go then? I guess are they just being connected within the hospital,
Right.
but is it a fewer number of patients overall?
Yeah. I'd say, I mean, it's probably still the same, but I think just the model looks different. We do still have acute rehab hospitals here, but they're usually attached to, you know, the acute hospital. But they're still getting the same care where they're getting the 3 hours of therapy a day, and with the goal of them going home. But yeah, I think a lot of it's just sort of how things were initially set up when the specialties first came about. And I mean, they are, say at UC Davis, they're starting to build, they're looking to build like a new freestanding rehab hospital. So that's probably the long-term goal, you know, but we're just taking a long time to get there. Yeah.
Cool. Thank you.
Mm-hmm.
Thank you so much for that talk. My question was actually a follow-up question to what Casey had, and I was wondering whether there might be more residency programs coming in California. Have you heard any word about that?
Yeah. I have not heard any word about that. Even within our school, you know, within UCSF, you know, that's sort of our ultimate goal is to get one for UCSF. You know, I'm hoping at least that they can increase the numbers of residents, just because, say, where I came from, there was only three. We had 3 students per year. So I think at least with these institutions, that would be the first step, you know, would be to increase the number of trainees.
Great, thank you. And then one more question I had, you know, I noticed that it sounds like a big part of PM&R is being kind of that team leader, almost more so than other specialties in terms of being in charge of a physical therapist, occupational therapist. How much does that play into your job? And do you feel like it could take away from like time that you actually spend on direct patient care?
Yeah, it's a really good question. And I think the specialty definitely draws people that are, you know, like working in teams. And I think it gives better care. So I wouldn't say it draws away from it, but I'm definitely communicating a lot more, say, with the physical therapist and my ortho colleagues. And so it feels, you know, much more like efficient care, honestly, because you're all getting on the same page about a treatment plan. So yeah, I'd say it doesn't really draw away from, you know, like things I have to do day to day. And in the end, like the patient gets better care. So that's sort of one reason why I like the specialty a lot. And that's probably like how medicine should be, right? You know, just everyone more on the same page and not as siloed. Any other questions?
I have a question,
Mm-hmm.
kind of very similar to the ones that have already been asked.
Yeah.
But so then, do you feel like on the West Coast, like students are more likely to do like internal or family medicine and like specialize in sports? And then like also, if you go that track, can you have the same type of practice as if you did a PM&R residency?
Yeah. I think that's a good question. So there's actually, in terms of sports medicine, there are, the fellowships are usually majority are family and then PM&R, but there's kind of exceptions to all of those. So I have seen people like, one of my old colleagues was a physiatrist and he did a family fellowship, or a sports medicine fellowship in a family department. So I don't think it's necessarily geographic at all. I think a lot of it's more just sort of what do you think is going to give you a better training to do sports medicine. And there's a lot of overlap. Like you could be a family physician and do a PM&R fellowship. But I'm biased, but I personally think like PM&R, it's like you're learning the musculoskeletal system, you're learning function, you're learning anatomy. So I think, you could come out of PM&R with a better, probably like knowledge base and kind of like better way to tackle sports problems. But I think there's also plenty of family physicians where they have strengths in their training too, like maybe more with certain like pediatric populations, because they're kind of seeing those more. So I wouldn't say it's geographic. And there's kind of exceptions to anything. I think it's more about what do you think fits you best in terms of what like background training you want to get.
Okay, thank you so much.
You're welcome. Okay. Well, I think we are good on timing. And you guys feel free to email me too. I know things are a little bit wonky with COVID. I think as things lighten up, I'm happy to like have people come shadow. I've done that, like a day shadowing, things like that. Because I know seeing things hands-on is very helpful. But yeah, hope everyone has a good day. And yeah, email me if you have any questions.
Thank you so much.